So I'm Julia Combridge, and I was invited by Jeremy Hunt to chair this review in its three component parts. On my left is Cecile Chandler, who is the Vice Chairman of the review. And the third member of our panel is Simon Whale, who is here on my right. And next to Simon is Dr. Valerie Brass, who is our secretary. And then on Cecile's left is Dr. Sonia MacLeod, who is our most important key researcher. So that's us, that's who we are. So I'm just wondering if you'd like to start just by introducing yourselves, just where you're working and who you are, where you're working.
First of all, I'm Ailsa Gebby, and I was the chairperson of the expert working group on hormone pregnancy tests. We're not going to talk about valproate today, just to pick up on what you said earlier.
Sorry, my mistake.
Yes. Thank you. So I'm a consultant gynaecologist working in clinical practice in Edinburgh, and I've worked in women's health all my professional life, in contraception, menopause, general gynaecology, infertility and obstetrics. So I'm very familiar with the risk and benefit profile of all the commonly used hormones in clinical practice. I recently stepped down as a director of the UK Clinical Effectiveness Unit of the Faculty of Sexual and Reproductive Health, which is the main body in the UK looking at evidence and translating that into guidance for healthcare practitioners. And I'm also the chair of the MHRA expert working group on hormones and women's health that reviews all products and medicines and drugs related to women. So first of all to Shirley on my left to introduce herself.
Okay, so I'm Shirley Bryce, I'm from the University of Surrey. I'm a non-clinical expert on the working group. I'm on the CHM as well. My background is as a toxicologist.
Great, thank you.
So I'm Diana Wellesley. I'm a consultant clinical geneticist working in Southampton. I specialise in prenatal cases, so see a lot of babies with congenital anomalies. I ran the birth or congenital anomaly register for Wessex for 22 years, and I've been a member of the EuroCat group or working groups for about 24 years. So I'm on the prenatal committees, their coding committees. I'm one of 3 geneticists that reclassify all the congenital anomalies that are sent to EuroCat from the 43 registers around Europe. And so I'm familiar with congenital anomalies and possible causes.
Right, thank you very much.
I'm Stephen Evans. I'm formerly a physicist turned medical statistician turned epidemiologist turned pharmacoepidemiologist, and I'm semi-retired but still employed at the London School of Hygiene and Tropical Medicine. I've been a European Commission appointed expert on the EU Drug Safety Committee. I have been the first statistician involved with the Bristol Royal Infirmary inquiry, and I've been involved in other inquiries. But my work is largely on safety of medicines and vaccines these days. I had a brief period where I worked at the MCA, the forerunner of the MHRA, and I dealt with the aftermath of the pill scare of 1995, and also dealt with MMR and autism, for example.
Right, well, what a wealth of experience we've got here today. Thank you very much.
So I've prepared just a very short statement on behalf of the experts, just for a few minutes to summarise our position in relation to the report, if that's all right.
Absolutely.
So we're very pleased to have this opportunity to discuss the findings of the expert working group on the topic of hormone pregnancy tests. So back in October 2015, independent experts, of which we are representative, from a wide range of scientific disciplines were asked to participate in this group to undertake the very challenging task of assessing a possible association between hormone pregnancy tests and adverse outcomes in pregnancy. Every member of the group came with an open mind, and in fact the majority of the group had never actually heard of hormone pregnancy tests, and no group member had any association with a pharmaceutical company or conflict of interest. The group considered the fullest possible data available to us relating to this topic and published its report in November 2017. There was an enormous amount of information to be considered, which the group reviewed with the highest level of scientific expertise and total integrity. final conclusions of the group were unanimous and in keeping with their terms of reference. We considered all available evidence on the possible association between exposure to hormone pregnancy tests and adverse outcomes in pregnancy and did not find a causal association. Taking into account all the different strands of scientific evidence, the group again unanimously concluded that any perceived effect was likely to be explained by chance alone within a normal population. However, because of the nature of much of the data we looked at, a weak association could not be ruled out or proven with absolute certainty. And that was our conclusion within the report. Hormone pregnancy tests existed in another era of medicine that's very hard to rationalise now. Women's healthcare has entirely moved away from that paternalistic style of medicine that we heard about, and now it offers, I hope, choice and informed consent. I would like to emphasise that the hormones within these old hormone pregnancy tests have been used for decades in clinical practice and continue to be used. We're very familiar with them in contraception, hormone replacement, and as treatment for gynecological conditions. And for many decades, norethisterone has been one of the most widely prescribed drugs from primary care. The doses within hormone pregnancy tests of both hormones are again within the normal range used in current clinical practice. And these are the exact hormones that have shaped millions of women's reproductive lives globally, with controlling their fertility, spacing pregnancies, improving gynecological outcomes, and well-being with hormone replacement. And indeed, these drugs were used in the past to prevent miscarriage. So this, therefore, is a very different scenario from the absolute tragedy of thalidomide exposure. The group relied heavily on the input of families throughout, and we hope they felt welcomed. Mrs. Lyne, their chairperson, attended every meeting as an observer, but as chair of the group, I was able to facilitate her to question every speaker after every session, which I hope she found helpful. And for all of us, and I speak on behalf of everybody here, it was extremely distressing to hear from families who have brought up disabled children into adulthood and have lived with this uncertainty of why their child was born with a congenital anomaly. In reviewing the scientific evidence, in addition, the expert group were committed to making robust recommendations for the future, which we did. And we hope that the safety of medicines used in pregnancy will have a much higher profile now within the UK regulatory framework, and reports of possible congenital anomalies associated with use of medicines will be promptly evaluated, because we can always learn from the past and do better. But our group did not have any role in commenting on the regulatory actions that took place in the UK at the time hormone pregnancy tests were used. That's all I would like to say at the beginning, so thank you for your attention, and we're very happy now to respond to any questions related to this topic.
Thank you very much indeed. You did say, of course, that you're independent
Yes.
experts, but I understand none of you, well, I think that you have put forward to us any conflicts of interest you might
Yes.
have, and we've received those, so thank you very much for that. Can I just say, you were setting out very clearly the recommendations and everything in your report, and certainly we appreciate the work that you've done with Mary Lyons and her group, but she is very critical, the group is very critical still about the findings of the expert working group. And just sort of thinking of the way that you did it, your conclusions and everything else, and of course the APPG, the all-party parliamentary group, has been critical as well. So do you think there's anything you could have done differently with hindsight?
I think we possibly could all come up with some answers to that. It was an enormous task. There was so much evidence that we had to assimilate quickly and efficiently. Stephen may like to talk specifically about the epidemiological aspect of what we might have done differently.
I think that we probably were not as clear in our report as we could have been in retrospect, and particularly with the criticisms levelled afterwards. for the reasoning behind what we said. Now, I've gone through all of that again, and I can see that we could have been clearer. We could have perhaps expanded what we'd said, though there is an enormous amount of epidemiological data if you look in the report. But the argument that we had in why we did not wish to put just the numbers together was not made as clearly as we might have done. And for example, there was a big meeting in America where a series of people made remarks about the idea of doing meta-analysis in this kind of area. And Sid Shapiro said, if the same systematic biases are indeed present across a range of studies, the only effect of meta-analysis is to reinforce them, to produce spurious statistical stability, and thereby to discourage further research. Moreover, it is particularly in the domain of low-level associations that the temptation to perform a meta-analysis is the strongest. And he was someone who worked at the Sloan Institute and wrote the key book on drugs and birth defects in pregnancy. He also wrote a paper called Meta-Analysis, Schmeta-Analysis, and he was against it. I wouldn't agree with him totally, and there were two others there, particularly Diana Petiti and Sander Greenland, who agreed with him that just putting raw numbers together from observational data was generally a very foolish thing to do, but that there were sometimes gains from meta-analysis of studies. And I was one of the authors of a publication that came out 3 years ago, Evidence Synthesis and Meta-Analysis for Drug Safety, where we set out, we think, where are the considerations for including observational data. A lot of people think that you shouldn't ever do it. You should only do it for randomized trials. When you've got randomization, it's always sensible to do meta-analysis. And some people treat meta-analysis of observational data as if it were randomized data, and they're very different. And the argument that we had in that book was that there are circumstances where observational data can be meta-analysed, but you have to be exceedingly cautious in your interpretation.
Yeah, okay.
And I think that we could have had more of that kind of argument in there, but it would have been argument that to many of us would be obvious. We know the history of that over the last 25 years, and it would have perhaps been better had we had expansion of that.
Can I just clarify, the book that you have there, that was written before the expert working group?
Yes.
So it was prior to that and it wasn't
Yes.
influenced by? Okay,
Yes.
thank you.
And probably nothing would have changed our conclusions at the end. We could have probably agonised over this for a lot longer. But bearing in mind the very small numbers we were considering, the exposure of potentially over 1 million women to this hormone over 28 years, it was such a difficult task to try and pull out any relevant statistics to the best of our ability, despite having some of the best experts on the group at the time.
But in some extent, that's come back to bite, hasn't it? Because, of course, that has been now a meta-analysis done, and, of course, there's a new expert.
But we considered it, and it's concluded in the report. Why we didn't do the meta-analysis is included in the report. We chose to do a re-analysis following the advice of our experts at the time. And I think that the findings still remain consistent and conclusive.
I've seen nothing that has made me change my mind. I'm ready to be wrong. I've been wrong in the past. One of the members of our expert working group published a letter in the Lancet pointing out an error I'd made this was around 40 years ago when I worked with on perinatal issues, and it was on the safest place of birth. But I didn't see anything since we published that caused me to say there's something wrong in there. We included data that were not included in the Hennigan meta-analysis, right? We did not exclude anything that they included. The only thing that was not included is a letter by some Belgians under the name Mira, and they wrote a letter pointing out that hormone pregnancy tests were going on being used in Belgium after they had been withdrawn in the UK and other places. And they remarked that the number of people who had it was so many, and they noted that in them there was one esophageal atresia, I think it was. They don't make any remark about any control group. They don't attempt to do that. Yet that has been used in the Hennigan meta-analysis as if it were a proper study. And they have assumed that in the others there was 0 congenital anomalies, and in 450 that just is infeasible, really. The other thing that we didn't probably make as clear as we might have done is that thalidomide had relative risks of at least 100. There are documented risks of 8,000 for the relative risk. And we're talking in the Hennigan meta-analysis of something that's 0.4. Right? So thalidomide is just so different. It was easier to detect because of the enormous relative risk. It was easier to detect because it had congenital characteristic defects. It probably affected nearly everybody who took thalidomide, and it caused more than just the limb reduction deficits. But nearly all of them were also symmetric deficits. And most of the time with drugs, you don't find one arm affected and the other arm totally unaffected. They may have different degrees of being affected. And had we had that kind of thing, then we would have said hormonal pregnancy tests are causing these problems. The conclusions we had, I would support. We definitely did not say we excluded it. We made it very clear that you cannot exclude a risk unless you show it has a benefit. So, for example, with MMR and autism, you can't exclude a risk unless you show that MMR prevents autism. And we said that at least twice in the report, that we cannot exclude a risk. That's obvious from the start, that you just can't do that unless you show a benefit or you show convincing evidence of an actual risk.
Can you explain then, because you've set out very honestly where you felt you could have been clearer, but certainly the patient groups and indeed the all-party parliamentary group as well have said on many occasions that why should they be the ones to have to prove the science? And they clearly have not enough confidence in the working group to actually accept your recommendations. Now, you've said that you should have been clearer on 2 issues and so on. Do you think that that would have actually satisfied these people who feel that the report of the working group was actually, really did not stand up? That's what they feel.
I think we would all defend the scientific rigour of the process, probably to a man. Obviously, the findings of the report were deeply disappointing for the individuals in this situation, and no one can underestimate the heartbreak and the misery they've experienced of bringing up children in this situation. But as others have said, the science has to stand and support and association.
So going back to the actual working group, I understand your expertise, and together it was quite a rounded, I suspect, committee. But in the course of your discussions and deliberations, did you find that there was excessive weighting in one particular part, one particular aspect of the science, as opposed to another?
I would say not at all. I think it very fairly covered all the different strands of evidence that we considered. toxicology, zebrafish data that we looked at in detail. That having 2 clinical geneticists on the group was extremely helpful in explaining baseline incidence of congenital anomalies. And for example, when Stephen and I spoke to the members of Parliament, there's a very poor understanding that congenital anomalies happen anyway. When anybody's having a pregnancy, you worry, is the baby going to have 10 fingers and 10 toes? And I think people find it hard to grasp that 2 to 4% of babies are born with a congenital anomaly just by nature alone. 1 in 5 pregnancies end in a miscarriage. So it's very, very hard to tease out an effect from the evidence that we were presented that there was any significant effect above that of nature alone.
We also looked at the type of anomalies.
Yes.
And in other things, if you look at thalidomide, we've discussed that, you get phocomelia. If you look at warfarin, you get nasal hyperplasia and stippling. And often you can find a reason. Here we looked at all the anomalies and compared them with anomalies that you might expect elsewhere. So we looked at the prevalence. There wasn't an increased rate. I mean, obviously we didn't have a judgment, but there was no evidence there was an increased rate of it. We looked for clusters of anomalies, so we went through them all. And even though the information we had on the anomalies that these people had was quite limited, there was no evidence of a cluster. There was no evidence of an unusual anomaly, unusual patterns. All the anomalies were ones that were commonly seen, had incidence of 1 in 4,000 or 1 in 800 or, people. We looked at combinations of anomalies. Did we more often see a heart anomaly with missing limbs and that kind of thing? And there were a couple of small ones that we would see in URICAT. And the only thing that possibly came up was there was a slight increase in multiple anomalies in the HPT group versus URICAT. But the URICAT group, multiple anomalies are, so that relies on more than one anomaly being written. And so for URICAT, we get anomalies that come in from 43 registries around the country. And then 3 of us curate them. Because if you have, for instance, spina bifida, talipes, club feet, and hydrocephalus, they're not 3 anomalies, they're 1. The spina bifida causes the talipes and the hydrocephalus. So that's not multiple anomaly, that's a single anomaly. If you have missing kidneys, you don't produce any urine, you don't have any fluid around the baby, that baby will then have small lungs, will have a small chin, may well have talipes. Again, that's 1 anomaly, that's not multiple. And so we do that incredibly rigorously for all the URICAT cases. And so I would say that we cut it down by 2/3. So probably the numbers suggested here of multiple anomalies is the same as we would get for URICAT before we curate them. But ours are very carefully curated so that we can compare the data from Belgium with the data from France, from Holland, or wherever. And so we do that, and have done it for many years. We tried to do it with the data here, but because the information was so poor, we had to err on the assumption that it was a multiple rather than it wasn't. So we absolutely could not be seen to be taking out any cases, or not that it matters whether they're multiple or single, but we were looking for patterns. So we erred on that, well, if we don't know, we'll have to call it a multiple. So I think that is probably evidence that, we gave the numbers we had, but in truth, if we were to analyse them, if we were to see each child or see all the medical reports on each person, we might be able to create that better and give a better evaluation. But I think there wasn't anything that came out from looking at the reports of individuals and what one would see on a day-to-day basis in prenatal practice. Most of the people I see whose babies have anomalies do not have a family history of that. They occur as a one-off. We don't know the reason for the majority of anomalies still, particularly like diaphragmatic hernias, like exomphalos, gastroschises. We still don't know the cause of those, and we might one day, but we haven't yet found that. And so the fact that there isn't an obvious other cause for some of these doesn't mean that it was due to HPT. It just means that we don't know, and we don't know for the majority of people, sadly, that I see. We are producing more genetic diagnoses, quite a lot, but that's still the minority rather than the majority.
So just returning to Primados, just to clarify for me and for the panel and for those who are going to look at the website to see what's being said, can you actually categorically say there is no causal relationship, no association no possible association between prima dos and these children that are being born deformed.
We cannot rule it out, and that's why within the report we say, because of the nature of the data we looked at, a weak association could not be either ruled out or proven with absolute certainty. We've been absolutely clear all along. We didn't find a causal association, but because of the nature of the data, it is possible. Either way, could or couldn't exist. If I may just pick up on what Diana said, mention one thing which I think is a good example of this. When the first signal that there might be an issue with hormonal pregnancy tests happened, it was to do with neural tube defects. And actually, on reviewing all the data, we found that actually there was not an association. And then the whole issue with folic acid and neural tube defects came to light. But that was the original trigger for thinking there was a problem with hormone pregnancy tests. And in fact, that now from the data that we have, we can say we did not find an association. But it was the initial trigger for thinking there was an issue.
So you are ambivalent about there being no causal association?
No,
can I just come in on that? Saying none is not necessarily terribly helpful. If you're saying there's a risk in 1 in 10 million, that could still be a causal association. We certainly can't eliminate that. We can be absolutely certain that this is nothing like thalidomide. That we can be absolutely certain of. We cannot exclude a very small risk. And the level of risk is actually that we can exclude is itself somewhat uncertain. But even a risk that is 1/10 of, 100th of the thalidomide risk, I think we can exclude. But a 40% increase, we certainly can't exclude. Epidemiology is at the limit there. You need randomized trial data to do that. And these days, one of the key things we do in assessing whether an observational study is reliable is to envisage the randomized trial we would do if we could. It may be unethical, it may be impractical, but we try and think of the randomized trial. And none of these studies, all of these studies except one, did not approach it in that way. The only study that we found and that Hennigan has found that looked at that is one by Torfs. And Torfs is the only one that compares different hormonal pregnancy tests, because if you were doing a randomized trial, you would find somebody who wants to have a pregnancy test and you would randomize them to one test or another generally. You might even randomize them to a test or no test, but you wouldn't generally do that. You would randomize them to different tests. And the paper by Torfs has description of hormone, serum and urine tests. They tended to be available at slightly different times. And so one of the interesting things in the peer review of the Hennigan report, Dr. Olsinko Grin says this: more optionally, the authors, this is Hennigan and et al., the authors might consider reflecting on the extent to which the association they identify implies a causal association. An association between the use of HPTs and birth defects has long been recognised and was rarely in dispute. And we don't dispute that. There is an association. But that is like going to the Bristol Royal Infirmary inquiry and saying that among those children who had operations for congenital heart disease, there were deaths. There was an association between deaths and being operated on in Bristol. But that is not in dispute. The question was, were Bristol surgeons having a higher rate of mortality than the rest of the country who were our comparative group? And so the whole object of these studies is to try and say, have we made a valid comparison? Now, Bristol argued that Bristol saw more severe cases. We could not find any evidence that that is so. However, with hormonal pregnancy tests, there is evidence, particularly from the Torf's paper, that those who got tests were slightly different, not in all cases, but were slightly different to those who didn't get the test. It doesn't mean that everybody is, and so somebody might have got it just at random, but some people got those tests because they were worried. Some people had it because they'd had previous problems in their pregnancies. And one of the things that you find in the Torf's paper is a very interesting graph, and I can kind of wave it to you here, and you may be able to see it. I don't know whether you can, but this is gestational age, and this is the probability of a death from conception. And the solid line at the bottom is their general population. And these wavy lines above them are all the different tests. And it shows you that all of those getting tests had a higher risk, and this is on a logarithmic scale. So some of it is enormously higher at different gestations. And so those who get the test, it isn't all of them, some of them get it randomly, but some get it at a different rate. And they have reasons for doing it. The other thing that is important is that paper is the only one that I could find that, in discussing these issues, makes it very clear that there is a distinction between serious congenital anomalies and non-serious ones. And so it's also important to say, when did I ascertain that there was a congenital anomaly? We talk about congenital anomalies as if you could say yes, no, and Dr. Wellesley knows that that isn't so. But if we look at the serious ones, the cumulative incidence at birth was 1.1%, at 1 year 2.5%, and at 5 years 3.7%. So it depends when you look. You've got to be very careful. You've got to make sure you are looking at the same time. And if you were doing a randomized trial, you would do that. If you look at non-serious ones, the rates for the same period were 1.8%, 6.2%, and 11.3% at 5 years. And there is data from Fiona Stanley's group in Perth that shows an enormous rise between 5 and 6 years, or around then, between 4 and 6, because when children go to school, they get a health examination, and you then find anomalies. And so you've got to be very careful in your definitions of these things. And most of these studies were pretty weak in doing that, to be honest. And that's why, taking the totality of the evidence, I listened. I'm not an expert in clinical genetics. I'm not an expert in the animal data. We listened to all of that, and the pattern from all of it was, we don't see a problem. But we certainly can't exclude a very small increase in risk.
We
never said.
Yeah. Just to pick up a little bit more on that, the wording of all this was very difficult. In our terms of reference, the first sentence was to consider all available evidence on possible association. And again, we know there's a possible association. That was why we were doing the report. Then when the report came out, we were criticised because we hadn't actually picked up on saying was there a possible association or not. But there is a possible association. And to have done all that work, we had to look at the evidence and then decide from what we considered relevant and important that we did not find a causal association. But everybody admits there is a possible association, and that's why the report was carried out in the first place.
Can I just...
Sorry,
I was just going to add, with the non-clinical data, the issues that we had there was we looked at all the animal data, so that was rodents, mouse and rats, lemurs, the rabbits, and then the non-human primates. We took on board, there was about 80 studies that we looked at, and we took on board the dose, what dose was given. We looked at the abnormalities that had been reported and considered now, looking at it on whether or not these were spontaneous or they were within the control data. We did talk to Professor Wilkinson about the zebrafish work, and at the time that we produced the report, that was non-published data, but we still considered that, and since then there's been the paper by Brown et al. But because of all that, and taking that into consideration, we didn't feel the non-clinical data supported a causal association. But that's the non-clinical data. Of course, there's a lot more then if we're taking forward with the clinical data. So I think for that side of it, non-clinical, we would say there was not a causal. We didn't feel that the data supported a causal association with the malformations seen.
Why do you think the patient groups then are so certain in their own minds that there is an association?
I think when you're looking at all of this, and yes, it was traumatic for obviously the patients that came to talk to us and for us to listen to what was said. But I had to looked at the science that was produced and looked at the scientific evidence, and I can sit here and go through it again and say that I did not feel, looking at all the data that produced at the time, actually produced a non-causal association from the data that I had been able to analyse at the time.
In terms of sort of looking and saying we considered all of the available evidence, one of the criticisms that we have heard is that not all of the available evidence was considered, and that's sort of the Vargasson paper, which, I mean, you have said you looked at, although it wasn't published at that time, and then the Royal College of GPs report by Norman Dean was another paper that's been mentioned. And also there's a 1972 Isabel Gall paper in Advances in Teratology, which is a much more comprehensive description of her original earlier paper, that I don't think you considered.
So Professor Vargasson's was quite important because it's current work,
yes,
and it was looking at using zebrafish, which is used as a screening tool, and there's no dispute about that at all. I think when I looked at the data myself, I felt that there was some areas that I would like to have questioned. Of course, at that point, it wasn't correct for me to question it, but it did go to 2 other committees to question. And it was around the actual levels to which the zebrafish had been exposed to, for example. The methodology, absolutely fine. They changed the membrane to allow for better exposure. Quite common, and that's methodology. But again, I'd like to have understood a little more about the exposure to which the zebrafish, and also how the zebrafish were exposed over a period of organogenesis, similar to the 2-day exposure that one has with the primidos. And so that's the sort of information I'd like to be able to understand. At the time, quite rightly, Professor Vargasson hadn't published that data. He kindly provided it to the expert working group so we could actually listen and understand what was being proposed. And since the publication, we've been able to have a look further. We always said that anything that was to come out, we would be very keen to review and to take that information forward. And any other data would be that's coming forward now, we'd be very keen to look at. The other papers, no, but we did look at documentation that did come forward. There was one mouse study that did actually show some malformations, but that was 30 times the equivalent daily dose of primidos used every day in the period of fetal organ development. The lower doses in that animal study did not produce the same malformations. So again, as a scientist, I'm having to balance the two, and I appreciate what we heard from the association, but I'm looking at it from a science, and I'm looking at the science that's being provided to be able to go through that. And on top of that, I was very keen to look at what Professor Vargasson has now produced with his group in Aberdeen.
And we definitely considered Isabel Gall's work. I can't remember exactly, we'd have to check back on which papers we looked at, but her name came up frequently and the data was examined. Stephen, you would agree?
Yes, I think that there was some republication of data. That's one of the problems. And it's interesting that Hennigan only uses Gall 1972 there. But she was particularly interested in neural tube defects. And at that time, in spite of what Smithell said, and he was a great hero in this field, it was not fully known that folic acid would prevent neural tube defects. And it wasn't until Wald and Kuckel did their randomized trial, which showed that giving folic acid to pregnant mothers prevents at least 80% of neural tube defects. And so an association with neural tube defects is in some senses inherently unlikely with hormonal pregnancy tests, because we know that it is almost entirely due to absence of folic acid in a mother's diet. And it's very interesting that, as far as I can tell, and you may know more about this than I do, it's just in October 2018 that the UK has made a decision to add folic acid to flour, is it? It's certainly or other foodstuffs, is that right?
That's right.
And so it's taken a long time to realise that that is so. So I think that anything else that we have missed, I haven't seen anything, and I've looked at what they have said. The problem is one has to have enormous sympathy. No, we didn't just deal with the numbers, we were concerned for patients, but it is not the right thing to do to abrogate our responsibility to truth in sympathy with patients. Many, many parents were totally convinced that MMR caused autism. And when I first led and funded the first studies beyond what Andrew Wakefield had said, I didn't know the answer then. But we have subsequently done studies and shown that MMR does not cause autism, at least not at any noticeable rate. But there are still people out there, probably President Trump, and certainly Andrew Wakefield, who believe that MMR causes autism. There are lots who do. And so changing the minds of people is terribly difficult. And when you're involved in a tragedy and you have been convinced over a long period of time, it's very difficult. To be honest, I sent an email to Mrs. Lyons following some things that were said in Parliament, where there were people who said in Parliament, as our expert working group had begun, they had said that we were all corrupt, essentially. They had said that they were utterly convinced prior to our expert review that there was a causal association. They didn't use that word.
The temporal time is also relevant, actually, because like anencephaly occurs 23 to 26 days after conception. People took HPTs. People then did not, the minute their period was missed, go for a test. They actually tended to go after 2 missed periods. A few of them might have gone after 1, but I've seen a few patients with this problem. Certainly, more than one. They said they took their pill after their second missed period. The anomalies would have well happened before that. So despite evidence, as Stephen says, because this has been a mindset for a long time, it isn't something that's, they want a reason, and it's very hard to prove one, except for, the gestation is very relevant here, and we didn't go into that in great detail because most people in truth couldn't really remember when they took it. But in those days, it was a tendency after 2 missed periods to test for pregnancy, or at least a couple of weeks after 1 missed period, when a lot of the organogenesis would have happened. And we couldn't really consider that because people couldn't remember, and it wasn't fair to imply something on them. But that is relevant, in fact, in one's association. And a few people I have met who I ask when they took it, and then we discuss development, and they. The ones I've met do remember when they took it. One was very young. She remembered she'd had 2 missed periods and was worried, and so she went for a pill and that kind of thing to find out about the pregnancy. So I think there are situations like that we weren't able to examine. We weren't able to assess those sorts of things because it's such a long time ago.
So there's so many variables involved, and the numbers of events, I think 253. Where maybe there were 8 million of these pregnancy tests issued in the UK, maybe 1.2 million women actually used them. So finding the denominators and trying to work out any effect is impossible.
But isn't that just one of the problems? That we know that how many may have taken it, or we have an order of magnitude, but actually the numbers that would have reported, that would have made the link, makes your job so much harder, because in fact you have so few cases. That's one of the things you were saying.
So few cases to work on.
So really when you're looking at that clinical side of it, actually you've got very little to work on. So
absolutely,
for the women concerned who now much later on think, okay, this is what happened to us, they still don't have this grip that you have the sort of evidence you need to be able to come up with a conclusion other than there was a weak association. One of the things I wanted to pick up from you, Professor Evans, You say you cannot exclude a risk unless there's a benefit. What was the benefit of taking HPT as a pregnancy test?
What I meant there was if there was a benefit in protecting from congenital anomalies, I was meaning that. Now, in terms of the benefit of taking it, my wife was pregnant with our oldest son in 1974, and I asked her about these things, and she said one of the things was that the urine tests that were around at the time took a number of weeks to come back. And so if you were a little bit instant, well, it's men who suffer from instant gratification, not women, but if you wanted an instant answer, then the hormonal pregnancy test did that. The other thing that I think Dr. Olzinska-Grin again points out, that it was something you could do privately. You didn't need to reveal it to anyone. You could go and take it yourself, and you didn't have to have a test result that anyone was aware of.
You couldn't get it privately there, could you?
No, you took
description.
it privately.
No, I see.
And the result was private to you as a woman. You didn't have a lab test result coming back through your GP. You had to go and get the test from a GP.
So we're talking about a convenience rather than any
So
therapeutic or in
there
any
was
other
certainly
way.
no. Well, some people at the time probably thought that it was therapeutic. It might prevent the loss of the pregnancy. That was a belief at the time. And of course they were giving things at even higher doses than Primados at the time to prevent recurrent miscarriage. And that was being done a great deal. And a number of the papers grouped together hormones given for recurrent miscarriage or threatened abortion with hormonal pregnancy.
So you didn't find any evidence of people discussing the benefit-risk ratio before prescribing this tablet, bearing in mind thalidomide had already occurred, so you'd imagine that people would be pretty cautious.
No, there was nothing like that. People were literally given something often from the top drawer that the GPs had been given as a free sample.
Did you have a view about that? Did you as a working group have a view about that?
We all found it very hard to understand that that could happen, but it was of its time. The pill had just been launched. This was riding on the heyday of suddenly there was oral contraception to help women, but it's anathema to how we practice nowadays.
Do you think, looking back, that was right? Did you have a view as a working group as to whether women were properly warned about the risks?
We, as a group, we had no remit to look at the regulatory action, so we had personal views, of course, that this sounded now to us totally unacceptable. But if I may go back to your very first comment, would we have done anything differently? I think we might have done more to support the families. They came on a busy afternoon of work. We had a fleeting opportunity to speak to them. They were very upset. And then I think inevitably the conclusions of the report were very disappointing. So I think if we could have spent more time speaking to them and helping them understand the language and the scientific methods. But during one of our final meetings, let's try to find something to make the families feel better. Let's say there is a slightly increased risk of congenital heart disease, and we actually had to stop and take a breath and say, we cannot do this. This is a scientific group. We must adhere to scientific principles and produce the report that is absolutely accurate. And that was difficult, and one feels so sorry for the families involved who brought in their children with multiple disabilities who are now young adult, and that was very upsetting for everybody.
Can I just ask you, you just said this was a free sample produced by the manufacturer.
Yes.
So was there any pressure from the manufacturers in terms of trying to ensure that this pill was taken?
I don't think so. It didn't sound as though it was being marketed with a particular commercial benefit. I think the pill was the big thing at the time that everybody was pushing, and millions of women were taking it in these early days. That we know
you mean
now,
the
contraceptive pill. Many women who were older and were smoking were just prescribed this pill. Everybody thought it was the best possible thing, and we now are much more aware of the risks and benefits and prescribe oral contraception very safely. But I think hormone pregnancy tests just came out at a bit as an aside, and people were given free samples, and it was just thought to be a little added benefit that GPs could give their patients. And it was also used for treatment of menstrual disorders. Women who had absent periods could be given this to see if they had a
I don't understand
bleed.
why they give them out as free samples. What was
That was very common practice in the past. Even when I was a junior doctor, we were showered with free samples from pharmaceutical companies.
But why this one to GP? I don't understand what the reason for it was.
There would have been other free samples.
Others
This is
as
the only
well.
one we're discussing.
Yes.
There would have been
There might have been drug lunches to promote oral contraception, and GPs were given this as free
But some of them
samples.
were given out on prescription.
Some were
right?
given on
Correctly.
prescription, yes.
And then the National Health Service would pay for it. So
Yeah.
The same thing happened with non-steroidal anti-inflammatories.
Mhm.
People were inundated with the latest new non-steroidal anti-inflammatories,
Yes.
and they'd be given out as free things. Now that happened a great deal more in the US, so that in fact in the US there were many women exposed to thalidomide through free samples prior to it being licensed in the US. And Frances Kelsey, who got the Congressional Medal of Honor from President Kennedy for stopping thalidomide in the US, didn't actually stop it. She stopped it being approved as a medicine, but people were given out the free samples. Another thing we were criticised on was in combining oral contraceptives and hormonal pregnancy tests. And we did not do this. We looked at both of them, but we didn't at any point pool the data between hormonal pregnancy tests and oral contraceptives. Some authors did, and some didn't. And certainly somebody like Bill Inman was enormously concerned about having a pill scare by making too big a fuss about the possible effect of a hormonal pregnancy test. And as you say and imply, there is no, that we know now, no therapeutic benefit to giving it. It was just convenience. And when there are other things that you can now rapidly get a pregnancy test for, then there would be no reason to have it on the market, and it will have been withdrawn as a precautionary principle.
But in fact, the MHRA timeline suggests that the predictor home pregnancy urine test was available from 1971.
Yep.
So in fact, there were these other things. If you were just looking on the convenience scale, there was something else. So we're left with this still being prescribed or given out as a sample. It's also the case, interestingly, that it's exactly the same components and exactly the same dosage taken in exactly the same way as for the treatment of secondary amenorrhea, for which Primodos was actually licensed. So in fact, it could be prescribed, and certainly the prescribing chemist, the dispensing chemist, would not have known for what it's being treated. It carried on being used potentially. The only record you'd have of why it was being used was presumably in the GP's notes. So it's exactly the same dosage for the treatment.
Yep.
It was probably also went on being prescribed, and certainly there's a letter that says it went on being prescribed even after it was officially withdrawn. One of the things, of course, is that medicines regulation regulates the industry and not practitioners. They're free to do as they wish, and one has to realise that. And I think probably, I don't know, my wife had trained in medicine by then, and I think there was this belief that these pills were giving women a hormone that is absolutely vital for pregnancy. Progesterone, as a natural hormone, is absolutely vital for a pregnancy to progress. You cannot have a pregnancy progress. The mother will reject the tissue that is implanted, and the progesterone seems to be able to prevent that. So I think there was a general belief that these things were good.
However, you did just say that nowadays it would be withdrawn as a precautionary principle. When would that have happened? Bearing in mind what we know now. It wouldn't have happened in 1958 when it was introduced.
I think it would, and you could see in different countries on the similar precautionary principle, it was withdrawn at various times. Some withdrew it before the UK and some withdrew it after. The best sensible thing would probably, given the availability of other things, would be to withdraw it for that purpose earlier. And certainly the suggestion was that. So I carry no flag for the pharmaceutical industry. I think they're giving these pills out to try and hope that once they've given out a few and had a good result, the GP will then write a prescription and they make money from that and not the others. It's like free samples of Coca-Cola given at Waterloo Station. They hope that you'll buy it next time, and that's part of the way the industry works. And I don't. The industry certainly behaved appallingly in regard to thalidomide. I don't think they were quite as bad in regard to this, but certainly I fought the industry over oral contraceptives and venous thromboembolism.
You talked earlier on about the lack of randomised controlled trials, and you also mentioned that there are times when we'd all wish we could carry out a randomised controlled trial, that it's either impractical or would be unethical. If you were going back now to 1958 and you were introducing something like this, what would you recommend as a way of doing it? Because one of the concerns of our review is to learn from the past to try and secure a better future, if you see what I mean. So could you just instruct us how you'd wish to introduce something like this?
I would want to have, if there was an alternative test, I would want to be interested in the efficacy of this test. The hormonal pregnancy test was not 100% sensitive or specific. It gave false results in both directions in certain circumstances. So
by efficacy, you mean does it work?
It doesn't work perfectly.
Yeah.
Then nothing in
work?
medicine
Yes.
works perfectly.
But you're asking the question of efficacy. Does it work?
You're asking me to go back to 1958.
Yes.
And I would design a trial comparing Primados with an alternative pregnancy test that probably existed, right? And I would randomise people to one test or the other, right? And I would then follow them up. At the time, I would probably not be terribly interested in their propensity to have a congenital anomaly. I'd be more interested in, did it predict pregnancy? Did it result in a live birth at a higher rate or a lower rate? Right?
And after that,
I would want to follow them up to see whether they had congenital anomalies.
And how would you want to do that? I mean, what are the methodologies that you would be...
We have methodologies now for following up people after randomised trials on occasions. The industry don't always do this, but on the whole, academics are a little bit better. We don't have really good tracking.
You're not talking about the yellow card at this point?
No,
something much more systematic.
No, right? Something much more systematic than yellow
but
card.
We don't always do that, do we?
We don't always do that. Now, most medicines these days have a pregnancy register because it's regarded generally as unethical to give treatments that are not intended for pregnancy to pregnant women. There is often a requirement, especially if Shirley has done some work and found a slight hint of a problem for a medicine, then there will be a demand on the industry to have a pregnancy register to record all the women who were pregnant who got that. And we had this for SSRIs, we've had it for a whole lot of other drugs.
So just on that, one of the recommendations is to look at sharing of data across the stakeholders, be it the industry, be it CROs, be it the patient groups that we all understand, and the academics. And last week we had the first of hopefully a series of workshops, but our first workshop on predicting safety of medicines in pregnancy, a new era. There was about 30-ish stakeholders from across the industry.
When was that?
It was held in the MHRA offices.
Yeah. When?
I think it was last Thursday, not last Thursday, the Thursday before. So we're at the moment, because I'm working on that, because that was one of the...
So this is a new initiative?
This is one of our recommendations.
One of the recommendations, and now we're working on those recommendations. And actually we had 2 sessions, a morning and an afternoon session. We brought speakers in from academia and the industry to talk about issues. And one of the key areas that came about was sharing of data. That came up in the morning session and it came up in the afternoon session. We had some other people there. We had the MRC representative And we also had the NC3Rs represented because they've done a lot of work through initiatives such as Crackit. So that's something that we're looking at now. There are a number of recommendations that we're working through. They will be circulated to the stakeholders, and we will put that together, and it will come back to CHM at some point. And I'm hoping that wasn't the one-off workshop. There'll be further workshops to then start to work through those recommendations.
It's incredibly difficult to assess the safety of medicines use in pregnancy. Most pregnant women are excluded from the standard trials of any new medicines, but yet we know women are having pregnancies who already have chronic diseases and maybe continuing, sometimes they're very potent medication. Women become ill during pregnancy and need to take drugs, and we're very poorly informed that whole area. And again, picking up on our recommendations, we want to do better and study that area more.
I think that's already happening. I've been asked to be on the evaluation of the congenital anomalies on 2 trials of drugs. So new one, then they're actually areas of drugs we've used before, but a new version of. And so there's now, I think people are listening to that, not only to us. I'm sure it's coming from other areas, but they're starting to do trials in pregnant women. So women who need medication for whatever reason, we're comparing this one to that one, or this one possibly to nothing, but usually this one to that one. And I think that is really starting. And it's been just in the last couple of years actually that I've suddenly been asked to join quite a few of the evaluating the infants at the, after birth, or the anomalies during pregnancy, and that's never arisen before. So I think there is a new era of really taking pregnancy and medication seriously.
There was a major initiative at the European Medicines Agency as well in the last 18 months. I'm sorry, I was looking as though I was being rude on my phone. I was trying to find the date of when the European one. Sorry.
Can I just go back to your report and the conclusion of no causal association? So, but you also say in the report, I think, that there's a known risk of genital abnormalities, such as virilisation. So, as a layperson, forgive me, but isn't virilisation a congenital malformation?
It might be, but it wasn't present. It wasn't present, I don't think, there was one incidence of hypospadias, which is quite a common anomaly, but I looked through all the anomalies within the last week, and there's actually a paucity of problems like that. So that really was not, and if you look at I don't know what page we're at here, page 55, it's comparing data. If you see genitourinary, it doesn't even come up. So so there was absolutely not an increase, which you might still be strong.
So there is an association, but you found no.
And again, nobody would maybe understand the dose of that. Northisterone is a progestogen, but it has a slightly androgenic effect like testosterone, and that's the effect you would get in a female fetus. But it did not come out in the data we looked at, but it's been documented in the past.
Maybe for longer times of taking it, because it was only 2 days. That's why it would, a good reason, makes sense that it didn't have an effect. But we didn't find that. It's been documented where it's been taken for longer periods, but for the 2 days.
So again, it is a nice example of how there was effect that shows effect on the genital tract, the sexual organs, and similarly with stilbestrol, which was another teratogen identified previously, it affected the genital tract. Again, these are hormones, which again goes against the array of anomalies that appeared in the group that we looked at.
Yes, but it does tell you that the hormone can reach the developing fetus.
Absolutely. We're not denying that, but they are hormones, and with stilbestrol and androgens, they cause effect on sexual organs and genitalia, which we know there are lots of receptors. And that goes against the other data we looked at, which was limb abnormalities, congenital heart disease, neural tube defects, etc. Quite different, but we're not disputing that these are hormones, and in high doses in particular circumstances for a prolonged period, they can have an effect.
So it was picked up in the animal studies, you're quite right. But again, it was the dose that you have to look at. What's the level compared to what we'd be exposed to in humans? You've also got to always be careful how we translate data that we see in rats, mice, rabbits to humans. Obviously, the closest is the non-human primate, but that, as we've said in the report, and as we know now, it does have ethical considerations, and also statistically, when you're looking at a non-human primate like us, they will produce one, if not possibly two, fetuses, and there's a longer gestation time. And that's not to say we shouldn't be doing it. What we are looking at are alternative methods, one of which is a screening method using, for example, the zebrafish. But that is a screening method.
Can I just follow up the point on the non-clinical studies? Because if we're talking about what might be embryo lethal, so we will have lost a proportion before anyone gets to look at them to say, and was it the malformations that caused the death in utero? So that's an entire group that presumably you've got no information on.
So it is very difficult, and I agree. And sometimes there will be some overlap between embryo lethality and malformations, but usually at very high doses. Often embryo lethal doses to the embryo is often an issue that may be due to some maternal changes as well. Can we see that? No, you're quite right, it's very difficult, because if you're looking at what we're often looking at is day 19 in the rodents, then when you take those fetuses and look at them, you can actually look at soft tissue malformations, skeletal malformations, by putting them into the various fixtures that you need to do. And you really need a very good eye to do that, and that comes with a lot of experience. But these are very tiny fetuses, very small, to actually be able to determine that. What you'd also look at, and I've done some multi-generation studies, what you also look at is resorption sites, and you look at any discoloration. Does it tell me if there's any malformation? No, but then I'm looking at that, I'm comparing dose levels and also my controls. And I think looking now, we have a lot more data on many compounds and classes of compounds, at both the historical control data. So I can look back and look at, if I've got a wavy rib, is that because of the compound, or is that because...
But that's what you can do now. The
Yes.
practice of those studies that we're looking at, and then presumably not in the same way. So we've really got partial data.
You couldn't, but I
At
think
best.
it's very difficult. If you could, and if somebody wishes to take that forward and to present a method which you could look at fetuses at day 13, between days 13 and 15, but it would to look at the malformations would take a lot of being able to understand and doing a lot of PUPs. And I think if we look at the data that we've currently got, I totally agree with you, it's then and now. But if we look at the data that we've currently got and have analysed that, I think I would stand with the scientific output and results of the data that I've taken forward.
Can I come back to another question, if I may? And that is about the governance processes around how your working group operated. Yeah. What were
The
Governance.
governance. The group reported to the Commission on Human Medicines, and they are the top-level independent group of experts advising the government. In terms of governance, the MHRA provided the secretariat and did that to an incredibly high standard. There was very careful scrutiny in terms of conflict of interest, particularly. Is that mainly what you're...
Well, I was thinking then, sort of, as you're coming towards the end, I mean, you are, of course, the experts, and this may be almost impossible, but presumably your draft report was not peer-reviewed as such by any other group of experts.
Well, we were reporting to the CHM, and in essence, that's exactly what they did. We completed the report and submitted it to them. They totally agreed with all the findings. We clarified, they felt our wording was not clear enough, so we did reword some of the findings, but nothing was changed. So in terms of governance, we reported CHM, they looked at it in great detail, fed back to us, and the only thing that happened was some wording was clarified.
Is that all? Because actually what we hear from the patient groups is that there were quite substantial changes between the draft report and the final report.
I would dispute that. They were done in a way that was on the basis of improving the evidence and the clarity. There was nothing more sinister or Machiavellian than that.
But what we've been told is that the changes resulted in a report that was more definitive, more definite about the lack of a causal association than the previous draft.
At the patient meeting, I did use the word strengthen, which maybe wasn't absolutely ideal. It was more clarifying the findings, but none of the findings were changed at all. But as you can understand, it was a very scientific report, so if anything, they made it more understandable from the lay perspective.
What
And that was
about
the clarification.
The forest grass, because So I gather that was in the draft and then came out of the final report.
Well, maybe Stephen, you'd like to respond?
What are these?
The plots.
They're the forest plots. They're there. The only thing that might be said is that in some of them, technically, some might have had a summary element that I would have insisted shouldn't be there, because it is this spurious accuracy of the numbers that you had, because most of them didn't adjust for confounding factors in regard to that. And as I say, Torf's was the only one. So I don't recall anything being extracted from there. All the forest plots that I can recall are there, and not only that, we have made it clear what our view of the quality assessment was. And you can see lots of red, which says not very good.
Can I just ask about that? So those 7 criteria that you applied, who decided on which 7 criteria to
Well,
apply?
we had discussion among ourselves and with epidemiologists in the MHRA, and we decided on those that were specific to our needs rather than using the Newcastle scale. The Robis scale was not fully developed then, and I'm one of the collaborators on the new Robbins scale that is to be used by the Cochrane collaboration. I've been involved with Cochrane for many years.
And when each of the relevant studies was assessed against those 7 criteria,
Yes.
was that done by one individual?
I think we didn't do it in a formal way of sitting down, and that perhaps you might criticise, but as a group we looked at whether we agreed with those. It might have originally been done by one individual, and we didn't look for concordance between those, but a number of us went through those and said, do we agree with them? And that possibly wasn't ideal, but I don't think there was anything that says this was a very high quality study, and somebody else says it's a really bad quality study.
Just so I'm absolutely clear, one person sort of went through and ranked them, and then you as a group sat and said, do we agree, do we disagree? So they weren't independently ranked by more than one person?
I don't think so.
Okay.
I can't be certain of
But
that.
you all chose the criteria. We
Yeah.
had a
Yeah.
big group.
It was all
The
agreed,
criteria
yeah.
were chosen, and we had a big meeting discussing that. So they were agreed and then applied by.
I'm being honest, I can't remember the exact process there, and it may be that compared with an ideal thing of doing it double blind and all the rest of it. One of the problems is, of course, here, is that if you are doing proper systematic reviews, you should have a protocol beforehand. And I imagine that Professor Hennigan had a protocol. He doesn't mention a protocol in there for his systematic review, and there may be one, but the very best quality stuff these days will pre-register a protocol. But we know that people don't keep to protocols, and when you know all the data, there's a very great danger of writing your protocol to get you the answer you want. And that's, as I say, I think there are some things that we did, but I don't think they affect our conclusion.
To go back to governance, every meeting was very carefully minuted, and it would be a question if there were particular queries relating to that. We could easily go back to the minutes and
It would be
see the
helpful
discussion.
to know whether that was or was not done in terms of the
Yeah.
independence. So perhaps you could come back to us on that.
The National Academy of Medicine in America, when they set up a review, they also invite from their members a peer review process to look at the review before it is accepted by the Academy. This didn't happen here. Do you think it should have done?
It's very difficult to answer that question. I don't think it would have changed the conclusions at the end of the day. This was agreed by others with the Minister of Health and the MHRA that this was the process to be undertaken, and we reported the CHM. That was how it was set up, and we fulfilled our remit to do that. That was what was decided. Many people wanted a proper public inquiry, and in fact throughout the process kept referring to it as the inquiry, and we had to rein it back in and say, no, this is a scientific review of the evidence.
Can I just add, because I sit on the CHM when the report came, so I sat back because I was asked questions by Professor Ralston, but actually it was for clarity, and that will all be minuted. It was around, is this clear? And we have lay members on the CHM who also contributed to that.
But on the CHM, you had people who were expert in the science that you'd evaluated.
Yes,
Yes.
absolutely.
But it certainly our lay member would have picked up, but that would be limited, but it certainly was really precise to go through that. Can I just come back on one other small point with the organogenesis? What we did through the course of the work is that we did also look at some experiments that had actually been taken over giving Primodos to animal studies in 2 days, but over the whole period of organogenesis. And although lethality was seen at the highest doses, what we didn't pick up on, or what wasn't reported rather, was any malformations. So if you like, that was the nearest we could get from the data at that point.
Yes, sorry, Professor.
I think, for example, had a different process been gone through, that the Academy of Medical Sciences was asked to review it, that would be a different question, and they frequently do have peer review through that process. But if you go to a public inquiry, you don't have peer review. When we dealt with the Bristol Royal Infirmary...
I'm thinking more about the Academy of Medical Sciences, because that's the equivalent of the National Academy of Medicine. The guidance that the FDA have on meta-analysis, it's interesting that they say they don't offer any guidance on observational study meta-analysis because it's controversial, and I was one of the panelists who provided guidance to the FDA on that, and they do involve outsiders, and I think that the UK is not always as good as it could be in doing that, but it's a process. If you go to the Bristol Royal Infirmary inquiry, we didn't have peer reviewers there in some senses. That was a very different review, if I may say so. Your review is very much a science-based review. You're looking at scientific evidence.
Yes, from the statistical point of view, we were trying to look at it as a science thing, and that was a key element. Was the rate of mortality in Bristol higher than elsewhere? And there's a lot of very clever science there from David Spiegelhalter, who's so much cleverer than I am. I think that we might have done something better on that, but that would have required creating a precedent for reviews of the Commission on Human Medicines that hasn't existed in the past. And I think that there are reasons to say one might suggest doing that in the future, but it's a very different way of working.
Can I just ask a question? The chairman of the all-party group for Primodos asked a question in the House of Commons, and I don't know if it was written or whether it was oral, but the reply, she was asking if the Secretary of State would make an assessment of the merits in the conclusions of the 2018 report by Professor Carl Hennigan on oral hormones pregnancy tests and the risks of congenital malformations. Now, the Minister replied that in line with the government's commitment to review any new evidence in relation to hormone pregnancy tests, the Commission on Human Medicines is convening a new expert group to conduct an independent scientific review of the publication by Professor Carl Hennigan, and she goes on to talk about the European Medicines Agency as well. Can I just ask you, on the Commission on Human Medicines that is now convening this new expert group, can I ask you what you think that group might achieve, and whether you've got any knowledge of who's going to be on that group, and how it's going to work? Do you know anything about it?
I'm personally not involved. Shirley may be the best person to CHM.
So from a CHM's point of view, and I don't know, I'd have to go back to the minutes and if indeed we have got anyone actually listed. So what normally happens is if working groups are set up, for example this expert working group, the CHM are asked first of all to look at the remit of the group, to consider what the working group is going to look at, and then to consider experts those expert names are taken forward, and they go through a complete review of whether or not there are any conflicts, etc., etc. For this group, I didn't put my name forward at the time. I was recommended, I believe, it will be minuted, by Professor to sit as the non-clinical expert, and I was happy to do so. But that's the normal process. But again, the MHRA will be able to clarify that process, and it will be minuted as to what the working group's remit will be and how that's then taken forward. And we have a discussion at CHM about that very area, and the CHM commissioners can put forward names to take forward as the experts.
But a definite commitment was made to reviewing any new evidence. Our role, in a way, has been completed with the publication of the report, but the MHRA will look at any new evidence and report back through an expert group, and with involving the European Medicines Agency as well when appropriate.
So an independent group from us, so entirely independent,
Yes.
and we have no influence.
So
like the ad hoc zebrafish working group.
yes,
exactly.
Yeah, absolutely independent.
Right.
Can I just come back and ask a couple of things, and just some of the challenges that have been raised? So coming back to this report, I believe I'm right in saying that the report says that the studies were outdated. We all understand that, but just to look at that it could be found that any association that they came up with was overstated, possibly. Is it just as likely that any association could have been understated?
That's a very good question. I wonder if I can just read something from Diana Petiti, who said, in the group of non-experimental studies in which the results of some studies are positive and some are negative, it is always possible that the positive ones are the result of bias or uncontrolled confounding, and the negative ones are free of bias and confounding, or vice versa. Even when all of the studies are in the same direction, they might all suffer from the same bias, or might all be uncontrolled for the same confounder. Like Dr. Shapiro, I believe that simply estimating effect size from a group of studies does not shed much light on the truth. So we have to acknowledge the possibility in theory that the studies have had a bias that is downwards. Some elements of what we have would be likely to bias results downwards. If you have misclassified exposure, you tend to bias results downwards. But that is only really guaranteed to happen if you have a single exposure and you have a single outcome. If there are other factors that are at play, then misclassification can work in the other direction. So it is possible that it's been exaggerated.
And was that said sufficiently well in your report?
No, that's one of the things we might. But on the other hand, what we could show, and there is evidence that particularly in studies of drugs in pregnancy, that there is a bias towards the results that are positive being published. Now, this isn't the same bias that you get with randomized trials. You can do tests with randomized trials because very big randomized trials will get published. But small randomized trials that don't show an interesting answer will not get published. I've got a letter, or at least I did have a letter from the editor of the journal Quarterly of Medicine where we'd done a trial, and he said, we're very sorry, we won't publish your trials because they're results because it isn't significant. And that kind of approach, in theory, doesn't happen, but still happens. And so I think a lot of the explanation of this is that people have done studies and the interesting bits are published. The other thing that happens is they may study multiple anomalies and they don't report on the one that was reduced, they report on the one that was increased. And that is a continual problem. It happens in randomized trials. It is always.
You can understand then from the patient's group point of view that frankly you're left here with, was all the available evidence actually looked at? What is it that we're dealing with here? And to come away after all of this work saying, you know what, I'm not quite sure. We're so much better further forward.
Well, when I began this, I thought there'd be very little evidence. I, having worked in perinatal epidemiology and published on all contraceptives and their effects, I thought there wouldn't be that much evidence, but we ended up finding very large amounts of evidence out there. But nearly all the things that will encourage publication are towards the positive results. And so while it is theoretically possible that some of those results could have been in the other direction, I don't think they are. And what we can say definitively is that in the Hennigan meta-analysis, the results are not adjusted. We would recommend, when doing observational meta-analysis, that you take adjusted results from people. And so, for example, in his presentation of the TORF's results, if you look on page 12 of 27 on my printing off of that, the TORF's one in figure 2 has 40 out of 203 events in the hormonal group. It's the last of the cohort studies there, and 2541 out of 17057 in the supposed control group. But that was not their control group. That was the totality of others. And in the TORF's paper, they wanted to use the other tests as their comparison group. And that, to me, is the right comparison group. And if I do that and look at the serious congenital anomalies only, and not at those that have accumulated up to 5 or 6 years, then I find that the relative risk, instead of being 1.4, is 1.12. And so we have actually got a bias upwards there by not paying attention to the proper design of the study. And so that is likely to have happened in a number of the others. They say in the paper that the important confounders have been taken into consideration, but they don't say what the important confounders are. Reproductive history for a woman who has had one pregnancy is a very important confounder. But most of the studies didn't have data on reproductive history. Only a few of them did. The other problem is that knowing that in your family there was a congenital anomaly might be something that isn't in the medical record and isn't down in your pregnancy, and that might be part of the reason for having a test. And that might not be there.
But that's a might. I mean, the evidence as to whether that group who took the hormone pregnancy test were in fact different to the rest of the population, the evidence for that?
Well, the only study we have on that is essentially TORF's, and that shows unequivocally that there is a difference. Right. Their previous pregnancy loss has a relative risk that is about 1.45 is my recollection, with a p-value of 0.401. And so that is a highly significant effect. And that graph I showed you shows that even prior to that, because they're looking at things at birth, prior to, from conception up to the point of 40 weeks or so, the rate of loss is much higher in those who have the test.
I'm going to bring this session to a close because we are going to go into another session, another oral hearing. But before I do that, I'm just going to ask my colleagues if they've got anything else they want to ask or state, and likewise with you. So, Sonia, anything else?
No, thank you.
I've got just one very quick point. On the draft report, before you went back to the CHM, am I right in saying that the phraseology in the conclusion was something along the lines of it wasn't possible to reach a definite conclusion on association, whereas the final report says there is no causal association? That's quite a big change, and quite a meaningful change, at the very end of the process.
Yes. Again, I think we need to go back to the minutes just to check exactly how that phraseology was changed. I don't think it changes the essence of our findings at all. And it was, again, our way of trying to just make it clearer. And again, it's the words possible, causal, that everybody became very unhappy with just right at the very end. It was done with the best of intentions to give greater clarity. And I don't think it changes the conclusions of our report. And I think we all stand by that conclusively and unanimously.
I think the wording says does not support. That's subtly different from what you said. Does not support.
Yes.
I didn't say it doesn't support.
Yeah, we're happy to go back and double check.
It supports no causal association. No, we didn't say that. It does not support a causal association.
All right.
And that's a scientific statement.
Valerie, anything else? Right. So if I could ask you, any final words do you want to say?
I apologise for talking too much already.
It's been very interesting. Thank you.
Thank you.
Can I just say that we'll send you the programme of our program. I'll get that sent over to you. And the only other thing I just wanted to point out in the slide from Professor Vargson, and it was something that I remembered at the presentation, but of course it was presented, and in fairness presented, Professor Vargson was presenting unpublished work. But again, from the science point of view, there is a slide that talks about partial recovery 72 hours after being placed in fresh water following 24 hours treatment. Again, this is looking at some partial recovery, not damage to eyes, ears, or the fins, which is still evident at 96 hours. It talks about dilution of the compound. But again, I'd like to understand a bit more about the mechanism behind all of that. And that particular one, I think, is something that I would like to, if I had the opportunity, to investigate further.
And I would just like to say thank you very much for listening to us today. And this was an enormous piece of work, I think, done to the highest standards. And I can't see it ever being replicated or redone. But we, as a group, totally felt for the suffering of the families who've been involved in this. And although we didn't find a causal association, we really hope the legacy of doing all this work will be that the recommendations are taken forward by health ministers and the government. Because we've tried to make this a forward-looking report, and anything we can do to improve the health of women and babies in this country will be very worthwhile.
Well, thank you very much indeed. I don't think we underestimate the amount of work you've done. Thank you very much indeed.